Thank you for joining Health First for the webinar, The New Normal, Reopening in the COVID-19 Era. Our presenter will be Dr. Don Cohen, who is the Chief Clinical Officer at HealthFirst. He is also a member of OSAP's board. Today, Dr. Cohen is going to share his expertise on infection control and managing a dental practice in the COVID-19 era. Dr. Don, I'm going to hand it over to you. Thank you.
Thank you, Damon. So if we could, let's go to the next slide, please. So this is what welcome looks like now. And I don't know if your offices are open yet or you're planning on opening them, but that's a heck of a welcome sign. It used to be in olden days, maybe we'd even offer an espresso. And now instead of an espresso, we're offering an antimicrobial wipe and a mask. And that stop sign actually is crucial because here we are and suddenly we welcome you as a patient back to our office, but hold on, we have issues we need to go on. So if we could, next. So what's happening now is we have a whole bunch of pre-screening questions. American Dental Association has a bunch. I've seen them all over the place. But the fact is we have a bunch of questions we need to ask every one of our patients. And it's not just the simple, hey, how do you feel? Have you had a fever over 104 over these last few days? Have you been coughing? We want to go even more extreme because the more questions we ask, the safer we can make dental treatment in our office. Partly for the rest of our patients, but we need to be much more selfish than that for our own protection and for our team's protection. So, bunch of questions. We need to scan every single one of our patients. And obviously that's a remote, it's touchless. And we're looking, the number that keeps coming up is 100.4, but the reality is those questions have to be part of it as well. The device you see on the screen next to the thermal scan is a pulse oximeter. Pulse oximetry has really come to the forefront at this time, unfortunately. And the reason for that is, as our lungs become less and less efficient because of the COVID-19 virus, our oxygen saturation levels tend to drop. And as they drop, that's when we begin to get into trouble. You're looking at, let's see, that shows 93 and 74. We really would like to see a number no lower than 95 on oxygen saturation, but at 93, we're not going to go crazy. And of course, that second number is our pulse. So we're going to use the thermoscan. We're going to use this device. But as we use this device, we have to make sure that we have some antimicrobial wipes because we've got to wipe this out externally and internally to be used. The final thing you see on the right is obviously a blood pressure cuff. It's a wrist cuff because they're the easiest to use. But the problem here is it's a Velcro type fabric. So if we would use this, we would have to use some kind of thin plastic sheath for it. And they do make those. Would we do this for every patient? I think not. But if it's a patient of record who has a history of hypertension, and we know our patient's records, and is taking any medication, any of that, or in our pre-screen questionnaire, we come up with some indications of any issues of hypertension, hypotension as well. Really important that we take this. As well, we need to record all of these measures. Really, really important. Next. Next slide. Tom, next. Okay, so one of the things that just happened, and this is happening to many of us in not just our Zoom calls, but all over, and that is there is a huge stress on our internet now. So for any of us, at times, we start to see that we are either losing our contact or it's slowing down. That's exactly what happened. I apologize. But to this image, I want us to look at this. This is on the right. That is an actual Starbucks restaurant right now in China. About a month or so ago, they opened up all of their restaurants. But notice how they did it. Each of those tables, those are blocked out. The gentleman all the way in the back corner working on his laptop, I guess he's done with his beverage. He's got his mask on. This is truly post-COVID. On the left, hey, that's how we were all sitting there. Somebody's going over a PowerPoint presentation or some kind of financial analysis, and we sit like that. That's all gone. Next. Next. So here we go. We're looking at our reception room on the right, because the one on the left, that was before COVID-19. And when we talk about before COVID-19, there were 5 chairs sitting right next to each other. At best, that would now be 2. The other thing is, going with that, it's a whole bunch of other things that are going to be different in our reception room. You would see a toy box somewhere, and in there, the fuzzy teddy bear. No more fuzzy teddy bears. There's no way to adequately disinfect that. And of course, children love the Lego sets and all the lots of little pieces. And can you imagine trying to spray and wipe and dry those? No more Legos. And you don't see a magazine rack in that picture either. There's no way for us to disinfect our magazines or newspapers. And the furniture that you see, well, that's good because that looks like a vinyl with metal. And that's the best thing for us now because we can wipe that down with antimicrobial wipes between patients. And that's a new thing, between patients. There's almost going to be a new job created in our office, new job title, the wiper. Wiping doorknobs, wiping chairs, wiping surfaces. And we're not talking about in our operatories. We're talking about in our general areas. But to the right is our new dental office. And there we are. We may do our pre-screening right in the car. We might even be doing all of the documentation that needs to be done. You might need a new consent filled out in these new COVID-19 times. I was on a webinar. I was involved in a webinar about 5 weeks ago with a major law firm in dentistry. And they're talking about having new consent forms in this day and age based on COVID-19. So there is so much that's brand new, but there are things that you would see along with those chairs in your reception room. You're going to see boxes of tissues. You'll see alcohol rub dispensers. You'll see antimicrobial wipes, a touchless dispenser for waste. And what a beautiful thing, rather than seeing that young lady with paper in her hands, having a tablet. So the tablet would be wirelessly hooked up to your management software. And all of the major management softwares in dentistry have the ability to do that. Because if you had a tablet, no more paper, tablets covered with a nice secure cover, and we have the ability at that point to simply wipe it down with an antimicrobial wipe. It becomes a major key issue for us. Also, maybe somebody's not at the car. Maybe they're not sitting in your office. Maybe they're on the computer with you in your Zoom, and it may be some teledentistry program they're using. Because we're finding, and I'm sort of blessed at HealthFirst, we have a huge number of customers in the dental field. And we get to talk to a huge number of them. And what we're finding out is many of them would prefer an online visit, a tele consult, rather than a live visit, because there's absolutely no risk that way of contagion. So it is a totally different time. These are all things we should be thinking about, because I'll go over this again. The ultimate factor of getting patients back in our office is going to be making them comfortable from their fear of contagion. How are we helping them? That becomes the ultimate piece to make them comfortable. Next. So if we look at this, obviously now things look different. If you look at the slide on the left, you can see what things look like. Again, nice, warm, cozy, and there's your receptionist who's wearing short sleeves, no mask, nothing like that. Well, the reality is things have again changed there. There's a plexiglass screen there now, little cutout at the bottom, because we do have to receive those checks and credit cards, most important. But the reality is there's that screen. In front of it, there's some wipes for the patient. There's an alcohol rub. The patient has been handed or will be handed a mask to wear at all times in the office, other than during treatment. Our staff member is now wearing a mask, not an N95 mask. The reason not an N95 mask is the receptionist is not involved with aerosols. And as we go further in this, we'll be discussing aerosols in dentistry. But if you look at that, that's what it was yesterday. Today, take a look at this operatory. This could be two chairs in an open bay next to each other. It could be, think of this in an ortho office. We have multiple chairs. Look at that hanging vinyl translucent protection. Now there's protection between the two chairs. You might also have things like the high volume suctions that we've seen that literally go right up to the mouth and absorb all of the aerosol. There's many new things that we're going to be seeing. So as we talk about some of this, it's really important that we recognize, again, our patients are nervous. So you're going to escort your patient back into the operatory. What a great time, as you pass, if you pass, your sterilizing area, to briefly explain your sterilizing procedures and how we use them to protect our patients. You can't overdo this. It may sound crazy. Patients want to know they're being protected. Oh, and a side piece, I learned this one. In that left-hand picture, when we now have plexiglass and somebody slides over their credit card, and you then record whatever or put it through the machine, you hand it back in a wipe, right? There it is. It's an antimicrobial wipe. Be careful. The antimicrobial wipe can literally totally destroy the signature on the card. Just a heads up. Next. Next. So here's our beautiful new attire. On the right, there's our typical dental team. We have 3 of our dental assistants, and on the left, we have our hygienist. Notice the difference in the mask that the hygienist is wearing. That's an N95 respirator. And why? Because this is all about the issues of aerosols. Aerosols generated in the dental office are declaring us as high risk for those employees, but only those employees, not our normal dental assistant, not anywhere else. If you are in an environment, and this would be the dental assistant, in the aerosol environment as well, assisting the dentist or assisting the hygienist, yes, they would need all of that and then the N95 as well, but no one else in that office. And again, we all understand there's a tremendous shortage on N95s. I've heard a million different things. You can actually send them out for reprocessing. There are companies that will do that. One of the other ways that I've seen and suggested is have a paper bag with the person's name on it. When they take off the mask, put it in the paper bag, clip the bag closed, and all those bags will be lined up and secured so that you can reuse those. It is a very common thing, unfortunately, in this day and age, to have to reuse those masks. And we're not only talking about in dental facilities. I have a son who's in a hospital system, and he has to reuse his N95 for 2, 3, even 4 days. So this is just how it is. On the left-hand side, we're looking at dental providers who have everything on, ready to go. They also have their gowns. They have their face shields, super protective, as well as they're all wearing N95s. These are probably dentists or hygienists who actually are creating aerosols. Next. So, if you're looking at this, this is not who we envision ourselves. That's a Tyvek type gown. Again, a shield, but a very specialized kind of shield. Head cap is part of the Tyvek gown. This is super special. The reality that comes in here is we're talking about positive situations on COVID-19. In positive COVID-19 situations, you would actually need a laminar airflow with negative pressure. Additionally, those direct suction machines with the extra arms on them would probably be necessary as well. Difficult times, not one that's part of our normal regimen. Next. Next. This was like one of the scariest things. Many of us on this call, I'm sure, subscribe to Dr. Bicuspid. Going back last month, I saw this and I realized this may be the exact gating issue for us being able to come back. Yes, the state governors have to give permission. Yes, maybe the ADA has to. Yes, maybe our state dental board has to. A whole bunch of permissions. But the reality is, okay, I'm going to let you now go back to work. I may even provide you with an unlimited supply of PPE, including N95s. The reality of life is, are my patients ready to come back in? And the more that I find myself talking with dental offices, small and very large, this issue stands out more than anything else. So if we wish to get our patients to come back, probably the most important thing that we need to do is to make them comfortable. And how do we do that? It's through a whole bunch of efforts, and it's efforts of everybody on our team. Because if we don't do that, the fear factor you see here is, let me get this straight. I can get my teeth cleaned because I know I'm supposed to do that every 3 months, 6 months, whatever it is, period maintenance, all of those things, because otherwise bad things could happen. But on the other hand, if I go into your office and I'm not kept safe, the worst things could happen. This is truly, how do we get into times that there is a fear of death? This is probably the only one I can think of. So this gets really, really, really scary. And notice those numbers, 71%. That's like 3/4 of every one of our patients. So there's a big job. North American Dental Group, for anybody who doesn't know, they've got like 180 offices. They're not a small situation. But from all of my conversations, whether it's a single operator office on the corner or a large DSO, we're all in the same boat. When we are allowed to open up to elective services, the question will be, are our patients really going to be comfortable enough to make the appointment? Really key. Next. Next. So this is an interesting slide, one that doesn't make anybody happy because it has those 3 magic words up on the top on the left. For how long? We've heard Dr. Fauci say that maybe by a combination of incredibly fortuitous situations, we could have a vaccine by the end of the year. Yet it appears, as we read anything with regard to learning about, first they have to test for safety, they have to test for efficacy. There's so many different things that if we were to look at what's ahead of us, 18 months would not be a strange number to be looking at. And when you're looking at that slide, you can see the big, big, big apex going up. The other 2 slides, and these are similar numbers that we've seen in the past. And then you see the dance. So the hammer is the big one, the dance. What is the dance? The dance is that we can expect, especially with social distancing and people tending to relax, that you're going to see these small waves occurring. And when will they stop? They won't stop, unfortunately, until we have a universal vaccine. People on occasion will talk about herd immunity. But as we're reading about herd immunity, that would take somewhere between 50 and 70% of the population to have been infected. If we think about our country today, we have about 325 million people, around 1 million COVID positive cases. And then we could say, yeah, but there's a whole bunch that were asymptomatic, non-diagnosed. So if we raise that number, from 1 million to, I don't know, 10 million. So we would have 10 million out of 325 million. The reality, that's still, what, 3%? We got a long way to go. And in order to get to that 50 to 75%, 70%, we need a lot more deaths. So social distancing is the only thing that's going to keep us from seeing huge numbers of deaths until the vaccines are available universally. Whole bunch of vaccines in the mix. Some of them say they're in the lead, some not. Got a long way to go. So how long? Long time. This article, by the way, called The Hammer and the Dance by Thomas Puevo, super article, talks just about these kind of issues. It's definitely not one that becomes a good bedtime story, but it's real. The link to it is down there for anybody who'd like to see it. Next. So, how can we reopen? We know at some point, I don't know what that time is. I wouldn't even dream of trying to predict, but we know at some time we are going to be able to reopen our office. And how are we going to do that? Other than the legal ramifications, so we leave out the ADA, we'll leave out the State Board, leave out CDC, leave out OSHA, leave all of that out. It comes down to a number of things. One of them is our staff. What have we done about our staff? Back a couple of months ago, we had the option, when we knew we were going to be closed, to either lay off our staff or furlough them. If we laid them off, they will have zero loyalty to us once we can reopen. It's just a thought we need to think about. If we furloughed our staff, it's quite obvious we cared enough about them to pay for their families' health insurance and their insurance, of course. So that there's obviously a level of loyalty that we were demonstrating to them. Will all of them come back? Nobody knows, but they certainly have a good reason to come back to you rather than to go hunting to go to a new office. Among the questions that will come out for them, of course, is, what are you doing about N95 masks? That question is going to keep coming. There's nothing that you can do to avoid that. But have you stayed in contact with your staff? Have you actually had, I don't know, maybe a Zoom call with them on a regular basis? Probably every week. Let them know what's happening. Keep them informed. Show your caring level. Separate phone calls to individual ones, even better. It's a great thing. But if you haven't stayed in contact with your staff, again, there's a great risk. And one of the keys that I would suggest, and this is sort of a left field suggestion, I would suggest that you do a SWOT analysis. And what is that? A SWOT analysis is an analysis that compares and brings all four elements of what you're facing ahead of you in any business. So that would be your strengths and your weaknesses, the opposite, your opportunities on one side, and your threats. And when you do this, I have to suggest that you bring in some very critical people. This is not when you want to be yesed. This is when you want your accountant who gets drop dead serious with you about your finances. Hopefully your office manager is involved and your office manager is comfortable enough sitting there and being critical. Likewise, anybody else on your staff who is comfortable enough to be critical about this. And then you need to sit down, go through each of those elements and figure out, how are we going to address this? Opening up your office when the time comes will not be all sunshine and roses. It would be nice to dream, but it won't be. Next. So PPE, no matter how you do this, you go back over to this. OSHA came out with a booklet, a 35-page booklet called OSHA COVID-19. And one of the key elements that we need to recognize, again, this is N95s, because they can be a key gating element for us. The reality is we create aerosols. If you create an aerosol in an environment with a suspected or possibly suspected COVID-19 patient, that's a high-risk area. We need to protect our staff and ourselves. And one of those recommendations is an N95 respirator. They can be had. Worst case, you can buy the very, very large commercial full face that almost look like gas masks. Do I recommend those? No, because I can't imagine having a little child sitting in a chair and you thinking that they're going to not jump out of the chair and run right out of the chair to their parents. But the fact is, those may turn out at times to be the ultimate need. And these are really key issues. You know, you have other gating issues that come up. And I'll just throw a few at you to think. One of them is literally almost all of the IMUs, the instructions that the manufacturers give us for use on our autoclaves say that after a prolonged delay, you should do a test, a biological test, and make sure you get back a negative test. Shouldn't be too difficult. However, that's going to take, if it's a normal mail-in, a week to 10 days. So think of that as a gating issue. So if you got to go ahead today, you might have to wait a week to 10 days to open your office just for that. The same thing would possibly come up on your amalgam separator. Your amalgam separator has a cartridge. Over the course of a month or 2 months, that material will all settle out and can actually become rock hard. It would be very advisable prior to opening to have a new amalgam separator cartridge. Likewise, for your suction system, I know you may change the filter monthly. This is a good time to change it before you open. Same thing about the little basket filter that you may have chairside for your suction and saliva ejector. I'd replace that. And the other part and pieces, you may need to shock your water lines. Again, although you may have bottles with straws or cartridges, the reality is you haven't had any water flowing through anything, and you've created a bunch of biofilm. Just some more points that we think about. Doesn't make it very easy, but we know we've got to do this. Next. So, have we stayed in contact with our patients? There are a whole bunch of ways we know. Thank goodness for social networking. We can do all kinds of things with Facebook, Twitter if you're into it, whatever, emails, create newsletters, blogs. But I got one that really, really, really would be pretty cool. And that would be, why not do a video tour of your office and make it short, 1 minute to 2 minutes. Nobody can tolerate more than that, even though your office is lovely. And in that tour, the only thing you want to show is what's different. What's different now, post-COVID-19? It might be that magic sign of not welcome, basically, warning. But it would then show your reception area with the reduced chairs. It would show all of the different items in there, from the alcohol rubs to the wipes to the touchless waste receptacle. The screen, the plexiglass screen in front of reception. All of these are brand new. They're different, but they make me as the patient maybe a little bit more comfortable that you really are going all out to make sure that we stay safe. You can't overdo this. I know I may sound like a broken record to everybody. You cannot possibly overdo this when it comes to making your patients comfortable. It is the prime stopper that's going to keep you from opening your office wide. You may get all of the restrictions on the regulatory side removed. Meanwhile, how are you going to get patients to sit in that chair and be comfortable when you read that 71% of them for one group were uncomfortable? And please, I ask you, that group is not unique. This is who our patients are. Next. So here's a weird slide. And I ask, whose patients are they? So if you go to sell your office, you're going to say, well, they're my patients. The patients of record go into that. And technically, absolutely right. And when you go further down, whose patients are they? Do they belong to the hygienist, the dental assistant, whatever? Well, I'm the dentist. They're my patients. On a technical side, legally, yes, without a doubt. But then the reality comes in. In many practices, they're actually the hygienist patients. Because if you think about it, in a situation where you have a good recall program, good periodontal maintenance program, good soft tissue management, in that, the hygienist is the one who spends the vast bulk of time with those patients. And unless they need operative dentistry or crown and bridge, endo, something of that nature, the reality is the dentist stops in, does a very, very comprehensive examination, but it only takes a few minutes, maybe 10 minutes at max. And all the rest of that time, the hygienist spends with the patient. And as a test of this, if you ever think back, if you attempt to call a patient up and say, hey, I know you're scheduled with Bob, but Bob's not available today as your hygienist, so we're going to substitute Susie. Is that okay? And the net result on that is, more often than not, could you reschedule me when Bob's available? So we need to plug in that our hygienist is the crucial person. And I picked that slide. No, that slide's not today. You know, there's no hair cover, there's no face screen, there's no mask, there's nothing, you know, there's no gown. But the reality is that smile and that image, that's who our patients think of as their hygienist. Whether it's a guy or a gal has no bearing. It is that image. It is imperative that we recognize that's who those patients, quote unquote, belong to. Next. So, what's the strongest way to restart? So in here, you're seeing an image of an office that's basically closed, and they're making calls. And this is interesting. This might be your hygienist who comes in a few weeks before your office opens up. And what does that hygienist do? That hygienist gets on the phone and immediately starts calling patients. And in parentheses, if you notice, I put families, because typically talking to either the mom or dad, who is the significant person, who then makes sure to bring the rest of the family in. And it's important, desperately important, during those calls that everything be explained to the patient, what you're doing to make them feel completely safe for this next visit. And when we talk about that, of course, we're talking about all of the enhanced patient protections. And I'm going to go over it point by point. This is not a 5-minute call. This could be 15 minutes, could even be 20 minutes. But that call with somebody who they have a true relationship with, can make the difference between them being comfortable. And at that point, there's where a hygienist starts talking about the basically oral health, systemic health connection, and inflammation, and explaining that obviously where there's inflammation, there's going to be some level of weakness or attack to the system. And that's why these 6 months, 3 months, whatever the appointments are so totally crucial to keep them, to keep your body from getting into that position. And they need to go through this in a almost in toto to everything that they know, they believe, and make the patient comfortable. And finally, the one important thing is they've got to ask the patient, do you have any questions or any areas of discomfort that you'd like to ask us? We want you to be totally comfortable. Next. And the final thing is, your hygienist needs to close the deal. Make the appointment, because that's what it's all about. We've got to make the appointment. We've got to get those patients back into the seats. And as we do that, the recognition is we better start off really slow. If you have, I don't know, if you have 2 or 3 hygienists, recognize you're probably only going to start with 1, or maybe you'll start with both at half time. And also, will you be having your full days? Will you have whatever it was, 9 to 5, 7 to 7, whatever your days of operation are? Will that be what you'll be doing? Maybe yes, maybe no. Remember, we have a lot of people working from home. Their time availability is different. And going along with that, you really prided yourself. I used to pride myself on, hey, I have an associate. I no longer have to come in on Saturdays. Yeah, well, that could be out the door. If it turns out that so many of your patients want to come in on a Saturday and shock and awe, maybe even on a Sunday, your life may be totally changed in this transition period. It's absolutely important. Realizing that every day we are going to test our own staff and ourselves. Thermoscan, using a pulse oximeter. And the best way to start as a thought, why not get yourself and your whole staff tested to find out that you are all negative in your testing, and be able to have your hygienist deliver that messaging as well. Plus, when we have that magic warning sign, that bright yellow warning sign, we also tell the patients, by the way, this is the testing we do on ourselves every single day, and we have all been tested to be negative. It's hard to imagine how crucial this is. And again, I apologize for sounding like such a broken record, but without this kind of a philosophy, it is going to be impossible for you to even begin to build up. While you're doing this, there's another risk factor that comes up, and that is whatever staff you bring in, you conceivably have the rest of your staff who are anxious or jealous. So wherever you had contact in the past, whatever the frequency of contact with your staff was in the past, this might be a great time to increase it even more. You can't promise because you don't know what's going to happen with regard to how your chairs and your schedule are going to be filled out. So no, you can't promise, but you need to provide encouragement. Without encouragement, you may lose even those that you furloughed because they just can't work that way anymore. This is really, really, really scary stuff for them. Final subject I'd really like to talk to you about is testing. Next. So testing, we're hearing all kinds of stuff about testing. We're hearing that a whole bunch of the antibody tests that were done, the FDA basically reevaluated 14 of the tests that were out there, and they killed 11 of them because they weren't effective. So testing is just a wild place to be. I don't know who out there has been tested. A few weeks ago, my wife had a cough and developed a fever one time, one night, and she's got, unfortunately, severe allergies, so do I, and she also has sinus issues. So I guess she had an infected sinus. Doc said, come on. We went out to the tent outside the office, 2 bays, you drive in, stay in your car. You know, the 6-inch swabs, wooden swabs that we use for placing topical? Well, they took one of those and I think they placed it all the way behind my eyeball. Supposedly it has to go behind your turbinates in your nose. It's not a great feeling. And that's what they did for both of us. Tests took a while to come back and they were both negative. We were really thrilled with that. But we realized, one, could we do that at our office? No. Those are called PCR tests, and they have to have a specific unit for that. And I think the unit's like 11 grand or something. So that's a whole nother story. So what can we do? Right now, we talk about things like, you hear antibody testing a lot. And when we talk about antibody tests, a few things come up. One, patients do not develop antibodies before, as you can see on the slide, probably 10 to 14 days. And that would be what's called IgM, which is a general, more of a general purpose antibody. And then the specific COVID antibodies, you won't develop for up to 28 days after. So the reality is that a great test as a screening test for our patients? Well, some interesting issues come out. First thing I'll talk about, population. We have approximately 325 million people in this country. Approximately 1 million cases of reported COVID. But let's assume that there's a 10-to-1 ratio of patients who have non-reported symptoms, and yet they still wound up going through this. So if you look at those numbers, that means that you've got about 10 million people out there out of 325 million, which if you start breaking down the silly numbers, it comes down to what? 10% max? It's really not, it's closer to 3% of the population. So if you tested, wouldn't that mean that over 90% of the people you tested would be negative for antibodies? So as a screening tool, it doesn't make a whole heck of a lot of sense if you could use it as a screening tool. And please remember the if. If's a big word here. We know about PCR tests. Those are the ones, you know, up your nose, whatever it is. Then we have these antibody tests, which basically are very much like a pregnancy test. They would do a skin prick, and then there'd be a bar, 2 bars, and over 5 minutes, 10 minutes, 15 minutes, they would change color or not change color. Wouldn't it be great if we could have a test that was an antigen test that we could do a simple finger prick, catch that drop of blood, mix it with a reagent, and within 5 to 15 minutes, we could actually see a color change. If we don't have a color change, we know you're good, or the color change goes one way for negative, one way for positive. That would be the ultimate trick, because before we would have a patient come in the office, we would immediately test them. So here are some issues. One, that test has been applied for to the FDA. It has not yet received an EUA. That's an emergency use approval. First thing. Second thing is, once a test receives an emergency use approval, it can only be utilized by different degrees of laboratories. And what do I mean by that? There's something called CLIA. CLIA is designated by the FDA. And the FDA says that in order to be the C and the L are certified laboratory, in order to be a certified laboratory, you need to have certain levels of testing and approval. The highest levels are the ones that now have the antibody test approval. But who are those? For us, those tend to be the LabCorps, the Quests, and any of those others. Those are the only two names I can think of right now, but you can go through them. That's the first level. There are levels under that, smaller levels of labs. And the final lowest level is for the healthcare provider. So the healthcare provider, this could be an MD, could be a dentist, can get what's called a CLIA waivered facility license. The FDA has the form online. I think it's about $150 a year. Send in your money, and now you get this. On the other hand, right now, none of these tests are FDA approved for that level of CLIA waiver testing. So can we test? Should we even think of testing at this point on our own? The answer is no, because we can't. And you know, CLIA waiver testing comes in a number of different ways. One of the ones actually comes to us in dentistry, and this would be, we have a huge increase in diabetic patients in our practice. And those glucometers that our patients have are basically called a CLIA waivered test. It's home use, but it's CLIA waivered. So you could say, why don't we then, at least on that side, why don't we have a glucometer and test each of our diabetic patients at each visit to make sure that they're in control and compliance? In many states, it is required, one, you need to have that CLIA facility license. That's one. And the second thing is, some states actually require that you have an additional license. I happen to be licensed in New York State, and in New York State, I need a separate licensing from the state on these CLIA waivered issues. So on these types of situations, the ultimate key that we always recommend, and this is a sidebar, but it's real and it's so huge, please bring in your glucometer and be prepared to test in front of us. So we've gone through a gamut of a whole bunch of things. I will say our offices are going to reopen. Our key elements in our office reopening are going to be the gating elements, and our gating elements are obviously our staff, the patients, and no matter how I do this, it's PPE. We need to recognize that those three elements have to be handled completely. Our staff, we can't make them comfortable enough. No matter what we do, we need to show them our caring, our concern, and our desire to bring them back full-time as soon as possible. Our patients, make a beautiful video of your office, make it 2 minutes long, but on there, show all the great things that you're doing. You might even show pictures of your autoclaves on there, but make sure that you're showing that. And it could be a guided tour by one of your staff going through the office. Super essential. Yeah, the other things that we do are really cool, but that's among the most important. We covered a lot of territory. Please feel free to reach out. There's my email address for anybody who has any questions on customer service at HealthFirst. There you go. And there's our phone number. Please, any questions anywhere. Likewise, because I am on the board of OSAP, I'd be glad to help on any of these issues I can. And thank you so much for your time. Stay healthy.